Welcome, everybody. And um, my name is Julia Priestley. I'm one of the joint CEOs of the British Thyroid Foundation. We're delighted that so many of you have joined us this evening for the latest in our series of Meet the Thyroid Expert webinars. The purpose of these events is to bring experts together to talk about key aspects of living with thyroid disease and to answer your questions. Now, usually this is endocrinologists and surgeons who are certainly experts at treating and caring for patients. But of course, patients are experts in their own body and how their particular diagnosis is affecting them. And a big part of our work is to bring in and reflect the patient voice. So this evening, I'm really pleased to bring together the combined wisdom and experience of an eminent thyroid surgeon and a patient who's recently had thyroid surgery. Miss Alison Waghorn is a consultant endocrine surgeon at the Royal Liverpool Hospitals. Alison is the current and the first female president of the British Association of Endocrine and Thyroid Surgeons, and she has a specialist interest in retrosternal goiters, parathyroid surgery, adrenal surgery, and pediatric endocrine surgery. And Mr. Paul Madgwick is a chartered occupational safety and health professional working as a director of health and safety. Paul has a particular interest in workplace health and well-being and is one of the BTF trustees. In fact, both Alison and Paul are BTF trustees, and we're very fortunate to have their expertise to steer the work of the charity. So between them, our experts will be talking about Paul's journey with a thyroid disorder and his eventual treatment with surgery earlier this year. And Alison will be able to explain some of the experiences Paul will have had along the way and the wider context of the diagnostic pathways and the preparation for and recovery from surgery. If you have any questions for our speakers, then please do add them to the Q&A section of your screen. We are recording today's session, so you'll be able to watch it again in your own time and share it with anybody who might be interested in it. The recording will be available to watch on our website and on our YouTube channel very soon, in the next few days, so as soon as we've been able to upload it. So finally, just a reminder that Alison will only be able to answer questions on a very general basis. As always, if you have a specific question about your own condition, your surgery, it's always best to consult with your own surgeon or doctor. And so now welcome to Alison and Paul. Alison, I'll hand over to you to introduce the session. Thank you very much.
Thank you so much, Julia, and it's a pleasure to be here tonight. How we're going to manage this is I'm going to basically ask Paul a few questions, and then what will happen. Sorry, I'm just putting my share up. There we go. So I'm going to ask Paul a few questions, and then we'll elaborate on a few things, and then hopefully there'll be plenty of time for questions for everybody else, both to ask both Paul and I what we think about certain things. So Paul, thank you for coming today, and I know you have a very interesting story, and I'm wondering whether you could just tell us how you came about being referred for thyroid surgery.
Okay. Hi, Alison. In my case, it was quite strange, really. I'd started off feeling really tired, but I do quite a commute for work, and then things sort of progressed on, and my eyes become really light sensitive. I wake up in the morning and felt absolutely dreadful, and unless I took some like ibuprofen or something like that, and went back to bed for half an hour, it wasn't good at all. And then we were away during the COVID thing. We were away in Norfolk. Rather strangely, I normally have a shave in the morning with a little tiny mirror, and we were in a big in a bathroom with a huge mirror. And I thought, oh my goodness, look at my neck; it's absolutely huge, and I hadn't realised that. I have some issues from an immunology point of view. So I went back to see the GP because I thought it might be that, and he had a look, and by this stage there was other bits as well. I was struggling to swallow food. So, you know, like sweet corn, peas, that sort of stuff were getting caught, and I having to sort of cough them up. Yeah, sort of bits and pieces like that. Sometimes I felt really, really poorly. And it just come on all of a sudden. So he had a look and he's like, well, I don't think it is from an immunology point of view. I think you need to speak to an endocrine consultant. So I got a referral to see the consultant, went to see him. He was really, really thorough. There was all sorts of things he did, loads and loads of blood tests. So thyroid function, testosterone, plasma mets, whatever that is, liver function tests, etc. I did a 24-hour urine capture for a couple of times, which was delightful. Had a barium swallow, ultrasound of the liver. He was really, really thorough. He was working his way through the process, trying to find out what it was. He also did an ultrasound of my neck, and then he went and had a CT scan done as well. And he worked his way through all these things. He also got me to see a consultant ophthalmologist. He wanted to explore for thyroid eye disease or neuroendocrine tumors. So thankfully, all the tests for that came back negative. All the tests came back in range. So he was saying, well, it looks like you've got a thyroid issue, and it looks like you've got goiters, but your thyroid's actually working fine. So he sort of got to a point where he could do no more. He's like, well, your thyroid function is absolutely fine, but there's obviously something there. So he exhausted everything he could go through. So he said, well, you better go back and see your immunologist. So I went back to see him. He looked at different things as well. He looked through all the results. He was trying to get his head around it as well. He felt that it wasn't an immunology issue. So because of my tiredness, I got to see a consultant around sleep apnea, and the consultant felt that that wasn't the case. And he also got me to, when I had a particularly bad day, I got 3 different sets of sheets. So I'd nip down to the hospital and get these blood tests done on the day where I felt really poorly. So we did 3 of them, and they come back where everything was in range as well. So at this stage, he said to me, well, you need to either, the choices are, you can either see an endocrine surgeon or an ENT consultant. And by this time, I'd seen Judith Nicholas' story on Your Body Uncovered, and there were some things in there that I thought, well, that's similar. Some of the things that she was going through, I was going through as well. So I decided I'd go and see the endocrine surgeon. Really, really nice guy. He went through all the tests, and by this stage, this had been going on over 3 years. So by this stage, he'd waded through all the tests, asked lots of questions, reviewed the ultrasound and the CT results. Then he undertook a physio examination. He could feel the goiters, and he assessed that they were quite large by this point. So he arranged for a new ultrasound, which took place, ironically, 3 years to the day from the first ultrasound. He reviewed the results, and he said that the comparison was that they'd grown significantly in the 3 years. And on that basis, he felt that surgery was possible. However, he did say to me that in his opinion, some of the symptoms that I've got wouldn't be alleviated by the surgery. So it was a bit of a gamble. But I'm pleased to say that I'm feeling a lot better for it now, and it actually paid off. So that's sort of the story. A little bit strange. And it was very frustrating how everything come back in range, which obviously is good, but not to actually get a proper diagnosis for something.
Yeah, so that's not uncommon with people who have big goiters to have your thyroid function tests in range. In fact, that's quite common. Right. Occasionally, you can have what we call a subclinical overactivity, but most goiters are actually have normal thyroid function tests.
Right.
So that is very, very common, especially if you have a benign goiter with multiple nodules, whether it be one side or the other. So it's very common to have normal thyroid function tests. I mean, there obviously are other people who have abnormal thyroid function tests who present with goiters, but it's not actually as common as with these multinodular goiters. It's very common to have that. So that's the thing. Obviously, all your symptoms, it was very difficult to know how much of those were all linked in with this large goiter. Swallowing, we can understand that that would be an issue, because when you've got a big goiter, it can compress the esophagus or the gullet. And sometimes breathing, they obviously explored sleep apnea. So breathing can actually also be a bit of a difficulty sometimes.
I did have some issues with the breathing as well.
So sometimes at night you find that you have to lie on a different side, or you find that you have to stretch your neck out, and you find it difficult sometimes to raise your head. Some people with big goiters, if they put their hands up above their head, they find it quite difficult to breathe. So those are the kind of things that I would say did sound as though they linked in with your goiter. The tiredness is difficult because you've got normal thyroid function test, so it's difficult to say exactly where that came from. But maybe your sleep wasn't very good because your breathing wasn't very good, and that can cause tiredness as well. So that was the kind of things. I know you had an ultrasound. Now this isn't your ultrasound, but this is a ultrasound, and so we would normally often do an ultrasound, but you didn't have any needle biopsy, did you? Because they obviously thought that all the nodules that they could see will all look completely benign. And that's quite common as well. If you've got a multinodular goiter, if they don't see anything that looks particularly abnormal, then they won't do a needle biopsy. Occasionally, they'll take the biggest nodule and do a needle biopsy of it. But if it all looks normal, then they won't always do a needle biopsy. If, however, you'd presented with one lump, then it's more likely that you would have got a needle biopsy, because with one lump, then there's obviously a little bit more suspicion about just having one lump, whereas people who have multiple lumps, they're much more likely to be benign. Okay, so some people might have had, so we have an ultrasound, and people would, if you ever get a report of an ultrasound, you probably didn't get that direct report, but it would have usually, we have a range of reports. So they would range from a U2, which is just a benign lump, okay, and there are multiple different types of lump that look like it. All right, so you have a 2, a 1 just looks like normal thyroid tissue, and then a U3 is a bit more suspicious, and usually all U3s would be considered for a needle biopsy. If you had a U4, it's even more suspicious, and U5, they're pretty sure that it's probably some kind of early malignancy. Okay, so if anyone's had an ultrasound, then those are the kind of things that they might be told, oh, well, it was slightly indeterminate, i.e. a U3, then we've done a little biopsy for you because we want to understand. Now, not all those will be cancer or anything like that, and a lot of them will have normal benign cytology, but at least then people might understand why some are put a needle in, whereas the U2 nodules, we wouldn't normally put a needle in. Occasionally, but that would be rare.
And who would do the needle? Would the radiographer do that?
Usually the radiologist or or consultant radiographer or whoever you've got doing it will normally do it. Occasionally you have a cytologist right next door to you, and they will do it. So it's normal that occasionally, and I think in some units, people, if there's a very obvious nodule, some people will now do it. Well, they used to do a lot without ultrasound, but nowadays we do most of it with ultrasound. But occasionally people will put a needle in a lump without ultrasound. The key about it is that you don't, there is a small risk of bleeding. So you will find that if you had a needle biopsy, then you'd get a little bit of pressure on it afterwards to try and stop any bleeding after they put a little needle in. So it's not a thing. So if you had the cytology, which you didn't have, but I thought I'd explain, because a lot of people get that and are waiting for results, then if they've got, they have this range again from 1 to 5, so it makes it very easy. So if it's a 2, it's benign. And if we had a nodule that was a U3 and Side 2, benign, sorry. And if that's benign, then we would probably, we don't always rescan it. We have a discussion at a multidisciplinary team meeting and decide whether we can just discharge somebody or whether we need to go further and rescan. But if they had insufficient, then we would normally redo the needle biopsy. If it's just a cyst, then we tend to just follow that clinically and then rescan if needed. But if you've got a Thy3A or Thy3F, or 4 or a 5, then that usually means there's something concerning. The Thy3A actually only has about a 15% risk of malignancy. So we often repeat that, and often they'll be benign. So we're not too bothered about that. A Thy3F has approximately about a 30% risk of malignancy. And then Thy4 about 85%. And most of the, never say 100% in this business, but Thy5s would be likely to be malignant. So those are the kind of things that some other people might have experienced. You didn't, but that's because they thought it was benign. Occasionally, people might have another scan called technetium scan, which basically is a scan looking at the activity. And you only have that if your thyroid's overactive. You wouldn't have it if your thyroid wasn't overactive. You wouldn't have this scan. Okay, so that occasionally will tell us the area that might be overactive. Okay, and in fact, there's a big multinodular goiter on the you can see lots of hot red spots on that one. That's somebody with a big goiter, perhaps a bit like yours, that has got hot spots and cold spots. That often happens with multinodular goiters, but you would not have had this scan because you didn't have an overactive thyroid.
Yeah.
But if you had, we would have gone for this scan first and then maybe for something else. Okay.
Okay.
The other thing is this may have been your scan. I don't think it was, because you had both sides that were enlarged, whereas this side's just definitely one side enlarged. And that's where we can see there's some narrowing of the windpipe. I don't know whether I can actually do this, but there's a narrowing of the windpipe and there's a big goiter sitting there in the chest going down. You can see that's a big wide bit at the top here. You can see a wide bit and everything else. So that's why some people have CT scans, especially if it's going down into the chest. It gives us an idea about how big it is, because that then we sort of know what we might expect. So those were a bit on the investigations, which I thought other people might have had. And occasionally people will have MRI scans if they're looking for lymph nodes and extent of disease, if there's some suspicion it might be malignant as well. Okay, so that's really a little bit on some of the investigations that you might have had, but you and your surgeon then decided, didn't they, that they were going to take out the whole thyroid. Is that correct?
That was the aim. Yeah, I had one on the left, one on the right, and across the front as well. Yeah. So yeah.
So they decided that was the best way. So sometimes we take out half the thyroid, like in this patient, I'd probably only take out half a thyroid to relieve the problem. But sometimes both sides compress, and if that's the case, then both sides need to come out because it's not going to relieve the problem.
Yeah. Okay. Yeah.
So when your surgeon was sort of talking to you about what the possible complications were, what kind of things did he say to you?
He went through them a couple of times. So he did it at the consultation a couple of the times, and then he talked about it on the day. So the sort of things he was talking about: infections, bleeding, blood clots, scar-related issues. I assume in terms of infection and just not healing properly, nerve injury and damage. Breathing and swallowing problems, a possible need for a tracheotomy, which obviously I suppose you have to go through all the variances, low calcium or damage to the parathyroids, and issue with the voice box, maybe damage to the cords temporarily or permanent. So he explained that the idea was to go for a total thyroidectomy. So obviously removal of the multinodular goiters as well. But he explained that sometimes when you open up the neck, there can be complications in there. So for that reason, he might only be able to do part of the operation and maybe have to go back again another time. But he said that was quite a small percentage that actually happened to. He also talked about thyroid cancer, which he wasn't expecting because obviously the ultrasounds didn't show anything that they thought looked nasty. And as you say, I hadn't had the biopsy. So that was what he talked about. So as I say, he talked about that during consultation, but then he talked about it on the morning as well and went through before I signed the consent form.
Yeah, so that can be quite so I always say infection actually in the thyroid with thyroid operations is quite low because there's a very good blood supply to the neck, so that's quite rare. But people who are diabetic, or sometimes when it's been a very long operation, then you've got a slightly increased risk of infection, and we might give a dose of antibiotics, but usually we don't actually. So that is very true. Bleeding is often a bit of a concern. Not that it happens very often, but maybe 1 or 2% of patients, just after the operation, it suddenly blows up and it's bled. And we always warn people that that's a possibility, but because the neck's got quite a small area to bleed into, we tend to often will take the patient back rather than just watching and waiting if it blows up. Right. And that usually needs to be done quite quickly, because otherwise there can be concerns about swelling and it can be difficult to actually do the anaesthetic. Yeah. So we do that. So some people might be, and so sometimes you'll be aware of that. The nursing staff will be aware of that, and the doctor gets called quite quickly, and things will move quite quickly if somebody had that swelling. But it is rare, but it's best to be aware of it, because then the patient's quite relaxed when you say, oh, well, you've got a big swelling here, you know, I'm going to take you back to theatre, so they know that that's an issue. So those are the things. The voice box, that's always a bit of a worry. I don't know whether you're a singer. Are you a singer?
No.
No. So I always say that because there's two little nerves. There's a nerve that supplies the main voice box, all right? Well, it supplies almost all the nerves in the voice box, called the recurrent laryngeal nerve. And we're always a bit worried about that. And obviously your consultant spoke to you and said, well, and I think why he said he might not take the other side was because if he thinks there's been damage to that nerve, the one side, he doesn't want to go on the other side until he knows that that nerve's sort of sorted itself out. Because if you damage both nerves, then that's the risk of the tracheostomy, you see. If you damage one nerve, there's not really a risk of a tracheostomy. The other thing is that they often do a little voice box check beforehand. Did you have that? Did they put a little tube down your nose? No, they didn't do that beforehand. No. So you probably had a normal voice, but a lot of people do a little voice box check beforehand because they want to see that the nerves are working well beforehand, because that means that they know then if there was a problem afterwards, then they know that it's something to do with the operation. Right. And so a lot of people will have what we call a nasoendoscopy, which you just put down the tube, a little tiny tube goes down the nose, and you go, ah, and then you can see how the basically the voice box works. Right. There is another little, and if that was damaged, if that nerve had been damaged, then you tend to get a croaky voice. Yeah. And it can be quite hard to talk, and also for long periods of time. So we do warn people, and we always ask them their profession. You know, you might have been a singer, an opera singer, or a Radio 4 presenter.
Well, that's it,
So those are the kind of things we think. There is also another tiny nerve, one that supplies one muscle in the voice box, that can, if it's affected, it's right high up. And if that's affected, then it can affect your singing voice. That's how I describe it. So if you were a soprano, you become an alto. And you can drop it. So it doesn't give you that range that you had before if you were a singer. But also if you're a teacher, it's quite important because it's more difficult to project your voice. Right. So that's another one. So that's from there. But the breathing and swallowing, you already had those kind of problems, didn't you, beforehand? And the swallowing, usually it's okay, but sometimes it's a bit sore when you swallow. I don't know whether you found that.
It wasn't too bad at all, to be honest. It was a lot better than I feared it was going to be. You know, the surgeon asked me, he said, so have you got any particular concerns? And I said to him, well, I've got 3 really. So the first one is, I've already said sort of about the immunology thing. So I get pressure urticaria. So basically, for everybody else, what that means is, say for argument's sake, I kneel down on a concrete floor. My knees will swell up massively, and my body creates too much histamine, so it's trying to protect itself, and it overprotects itself, so then everything swells up. And my big concern was that obviously I didn't know how rough the surgery would be, how invasive it was going to be, and so I was concerned that it would be stitched up and then it would swell up afterwards and split open. And I'd already spoke to the immunology consultant. He said, well, speak to the endocrine surgeon, say to him about that. And what he'll probably do is he'll give you some steroid, and that will ease the situation. So when I spoke to the surgeon, he's like, yeah, we'll give you a good amount of steroid and then that'll be fine. And sure enough, it was. Obviously, the voice box thing was in the forefront of my mind as well. I explained that to him. I think he realised I wasn't a singer, but I think it's one of them things. It's something that you'd just be horrified if something happened, and obviously, he tried to allay them fears, and he was explaining about how things are monitored as well to make sure that the nerves don't go through any stress through the operation. And then the third thing was the parathyroids that he was talking about, and he was explaining that they basically regulate the calcium through your body, so for healthy bones and everything else, and that there's 4 of them. They're about the size of a grain of rice each, very delicate. And then he said, oh, and the other thing is as well, they're actually fed off the blood supply to the thyroid. So we have to backfeed them as part of the process, because you need to keep your parathyroids, because otherwise you're going to have calcium issues in the future. So that was a concern. But as it turned out, he explained after the surgery that there was a couple that had been bruised. But he could see from the testing that the calcium was fine, the levels were fine. But so they were the 3 concerns I had. So
fair enough. And it sounds as though he was using what we call intraoperative nerve monitoring, because he said it sounds as though it's being monitored during the operation, which is now more common. So people do use that. It helps us understand what's happening to the nerve during the operation, and can see, and we know whether we're pushing and pulling it. So it can be very helpful. Now, okay, let's get on to the day of the surgery. And so what happened on the day of the surgery, and before and after, just a small, the kind of thing that happened to you?
Yeah, so I had to go in the day before, so they did some more final blood tests. And interestingly, which I didn't even think about, one of the blood tests was to establish what my blood group was, just in case there was any blood needed. So that was quite interesting. On the day itself, I turned up the hospital at 8 o'clock, met by the nursing staff that went through reams and reams of paperwork and questions and everything else. And then supplied with a gown and these lovely surgical stockings, which were incredibly tight. And then I realised I had to have them on for 2 weeks after the surgery, and you could only have them off for sort of an hour. So that took some getting used to. Then the surgeon came along before he'd started his list. He went through everything again, went through all the potential issues that we've already talked about, and then obviously signed the consent form. So he went off to get on with his list. The consultant anaesthetist, he came and saw me as well. He went through the same sort of things. Did I have any allergies to certain particular things? I guess because of what he was going to be using. He had a feel around my neck as well to see how it was, and got me to do some breathing to make sure he was happy with that. And then he went away, and that was it. Then it was just the waiting game then. And then at some point, one of the anaesthetists or whatever within the team come and got me. We walked up, went in the lift, went to theatre. And they tried to keep me as calm as possible. Cannula in the wrist, and he obviously put some stuff in there. And I mean, I've not had an operation like this before. And whenever you see it on the telly, it's like countdown from 10 or whatever. There was none of that. He's like, well, I'm giving you this. This will calm you down. And I'm like, oh, I feel quite woozy. And he's like, well, don't fight it. And that was it. What I did notice on the theatre table, and I don't know, and I've not asked this before, there was like a big sort of balloon type thing at the top end of the table that looked like it could pump it up. So I don't know if that sort of moves you further backwards so you've actually got better access and that sort of stuff. But I noticed that. I thought, well, that's a bit strange. And that was it really. And then I remember coming round in the recovery room, and I was moving my hand around, and one of the nurses saying, "I wouldn't touch that if I was you. That's your wound." I said, "All right, sorry." So, and then the next minute I woke back up again, and I was back in the room, and there was some nurses there, and the wife was there, and that sort of stuff. So yeah, it wasn't as, I built it up in my own mind that it was going to be a really traumatic thing, but it was fine. It was fine.
Yeah, so I think, well, the balloon, I think probably, so what we do is we often ask people about their necks actually before the operation, because some people have quite stiff necks.
Yeah.
And then you put a little thing behind the head, and then sometimes around the shoulders, just to extend the neck out.
Yeah.
And that sort of brings the thyroid up a bit.
Yeah.
So that almost certainly was that. Occasionally they do use things to help you intubate, but I should think it was more to do with that in the right position, because that's what we do for most people, just extend the neck slightly before an operation, when we do the operation. So I should think that was that.
Yeah, because I guess you'd have to be lent back, because I know, like, obviously there was no pain to it, but there was then bruising that come back sort of a week or so later. I ended up with like orange bruising right sort of halfway down my chest. So I assumed that was from like stretching back,
Well, I think that was just probably from a little bit of bruising. It is a very vascular area. So what does happen is that even though we do very meticulous, what we call hemostasis, i.e. trying to stop any kind of bleeding, and we often put in something in the wound that will dissolve, that helps with it. And I think you had that. You didn't have a drain, did you?
No. I didn't, no.
Some people do put small drains in just overnight, just to take away the excess fluid. It won't stop a big bleed, but it will take away excess fluid.
Yeah.
And others don't. But that's why there's sometimes a little bit of extra fluid, and that will have just made the bruising just down at the bottom, which is very common, with a little bit of bruising just down the bottom. So that would be quite common. We do sometimes use steroids just to keep anyway, even though you had it specially for your urticaria. It decreases the swelling around the esophagus and also the larynx, so that can be quite helpful for us. Also, you probably didn't have that much pain, because people will often put a local anesthetic in, whether you put it in around the wound, or whether you some people do little blocks just in the side of the wounds to help. So and actually it's not a very painful operation. Usually just paracetamol and maybe a little bit of codeine, but not usually very much else, especially if people have put local anesthetic in. It tends to be not a particularly painful operation at all. And with some people, not with you, because you had a bilateral, you had both your thyroid out. Sometimes small hemithyroidectomies would be done as day cases, but obviously you stayed in overnight because you had both sides done. And the risk of problems with bleeding with both sides being done is higher. But most people, even if they just had half out, would normally be staying in the hospital for about 6 hours just to watch, because if there's going to be bleeding, it tends to happen in the first 6 hours. That's when it tends to happen. It doesn't always, but that's when it tends to happen. So those are some of the other things that were there. And then so what happened when you were discharged, and what was your follow-up?
Well, so that evening I had some more blood tests done. And I had some more blood tests done the following morning as well, and they wanted both sets back before the surgeon would discharge me. So he came along later on when the results were back, and just had a look. I must admit, so how mine was done was with dissolvable stitches. I was convinced that it was stitched in two halves. But he said not, because it just seemed weird, because there was dissolvable stitches, and then there was like this really sticky tape put over the top of it to protect it. And I managed, when I went back to see him, I'd managed to get this sticky tape off, and half of the stitch had come out, but the other side, the left-hand side, which I think was the bigger goiter, that took a lot longer for the stitches to come out of there, which was quite weird. And the thing that I didn't look at it either. The first day, I didn't really want to have a look at it, and then I knew before I was going to be discharged, I knew the grandson would want to come round, and so he's sort of 9 or 10 at the well, he's 10, and I just didn't want him to be scared. So I ended up, I took a photo of it and sent it to my son just so that he knew what I was going to look like beforehand, because there's one thing, and I assume you've obviously got to have a big enough space to get out everything you're getting out. It's not keyhole surgery, so the size of the wound depends on the amount, the size of what you've got to try and get out as well. So yeah, so he was okay with that because he'd seen that beforehand, So, but yeah, so going back to the discharge, the surgeon come round, he looked at both the results. He was happy with that. I'd already taken the first lot of my thyroxine. So that was it. I was going away from there. It, I was quite nervous about the drive home as well, obviously, because I'm thinking, well, this is really, really tender. So I made sure I got some padding to go around where the seatbelt was coming across, and I think the wife was quite, she was quite nervous about driving back as well, because she was conscious, and obviously, with potholes and everything else about it, it was a bit, but I think the pain relief was really good. And what we did when we got home, we kept to the same times that we'd had at the hospital and wrote it down the pad as well. So rather than either giving it too early or giving it late when the pain started to come through, we tried to be regular with it and got rid of the co-coldamol as soon as possible, because that was horrible. So.
And it gives you constipation as well, doesn't
it? Yes, yeah. You had to take this horrible liquid with it as well, which was which wasn't nice. No.
I suppose a few things just from that. The blood tests, I think they were almost certainly calcium levels and parathyroid hormone levels, which most of us will do. Either the parathyroid sometimes in the evening of the operation, because they've got it will be low if it's going to be low then, or a lot of people do it about 6 o'clock the next morning with a calcium, and then you can read it and you know whether someone's going to be okay or not. And then you can give extra calcium and vitamin D if needed. And then you know whether they're going to be okay. If the calcium drops dramatically and the parathyroid hormone is low, then you will probably stay in one more day just while they just sort out the amount of vitamin D and the amount of calcium that you need to have. But occasionally people will just do another calcium bit later on to make sure that they're okay and they're on top. So it's a balance, but that's what it is. I think the only other thing was the glue and steroid. Everyone does it slightly differently. Okay, so some people use clips. Most people now use what we call a subcuticular stitch, which is just one stitch, whether that's a dissolvable stitch or whether that's a stitch that's removed. It depends on the consultant. And also they often put glue on it, and often steri strips as well. So it is that's what you had. I think you had some glue and you had some steri strip. We like to keep people not fiddling with the wound. So we do everything we can to stop that. So those are the kind of things that most people would do. Sometimes people, when you came back, some people do get a little swelling in the neck called a seroma, where you collect a little bit of fluid. Usually that will settle. Occasionally we do take off a little bit of fluid after the operation, but mostly it just settles down by itself. So you may have been slightly swollen. And I'm glad you said about the codeine. You want to get off that as soon as possible, because you get constipated very easily, and you need to be aware of that. And usually just paracetamol every 6 hours will be fine. So that's also something. And just having your levothyroxine straight away, they've taken out the whole thyroid. When people have half a thyroid out, we wait 6 weeks just to find out what the thyroid function tests are, because 10 to 20% of people who have half their thyroid out will need a bit of extra thyroxine. But when you've got the whole one out, you've got to have thyroxine, so you can have that straight away. I suppose you were a little bit about what you did. When did you start back at the gym and driving and all that kind of stuff?
Well, I mean, when I went back to see him after the 2 weeks, so we sort of had a catch up. He'd said at the time that when the goiters were taken out, that they were a lot bigger than what he'd imagined, even from the ultrasound. And the left-hand one was a lot bigger. I mean, he was talking sort of 6 centimeters wide, and it went all the way down. It went underneath my collarbone, which he obviously couldn't see from the ultrasound. So I think in some way, whether that was impacting on everything under there, and that's what was causing some of the symptoms, is possible. Yeah, he was really surprised that they were a lot bigger than what he was expecting. Yes, when I spoke to when we went back and was talking to him, asked about driving, he's like, well, you know, a lot of people say 6 weeks, but it's really down to yourself. You've got to be comfortable yourself. You've got to understand that, you know, if heaven forbid it didn't happen, but if you're involved in an accident, you had to emergency brake, and that's going to dig in. And also you need to make sure that your neck's mobile enough that you can look fully left and right, because otherwise you shouldn't be driving. So that was his advice. So I left it probably 6 or 7 weeks before I drove. And then with the gym, he was saying there, well, really, you know, with anything like that, you need to gauge it yourself. You need to not go mad. You need to ease yourself into it, and, you know, just be conscious what sort of exercises will be pulling around your neck. So you want to steer clear of them. So probably legs is the thing to do. Spend some time on the bike rather than pulling huge weights that could be pulling at your neck. So that was really, and he was quite relaxed with that. And I've been really, we'd had the leaflet that said, you know, you must keep your wound dry and everything else. And so it's like, so we ended up with like a little towel and wrap it round, tie it round your neck, and then tie it with a safety pin so that I could get me hair washed over the bath and then get in the shower without getting it wet. But he was quite relaxed about it. He's saying, you know, after a few days, these things are knitted together anyway. It's good not to get it soaked, but you know, yeah, you've just got to sort of go with it. But that worked really well, to be honest.
Yeah.
So.
It does heal. I suppose scars take about 30 days to knit reasonably together, but then, you know, they take 3 to 6 months, sometimes a year, to just finalize and just become, and often at about 6 weeks it becomes quite raised and red. It becomes a bit worse. You think, golly, this has got a bit worse. And that's very common. And then it sort of settles down and then usually becomes a white line. I mean, there are occasional people that have quite raised red scars, but often they'll settle down. But don't worry, at 6 to 8 weeks, if anyone finds that they've got a little redness, that's quite common. So that is quite common. I think driving, yes, you cannot blame the accident on your operation.
No.
Because it's not going to go down, and you lose all your insurance. The other thing is that some units do give neck exercises just to turn your head, nod your head a bit, but you don't want too much stretching. You want it to knit together 4 to 6 weeks, and then you can begin to doing a lot more. And then sometimes if it's slightly ruffled, you can massage it if needed, but if it's not, then the body's just healed it well. So that's brilliant. I think, is there anything else you want to say, Paul?
Well, the only other thing that I was going to say was that, which I found really useful, was as soon as you get home, it's really difficult to sleep because it's putting pressure on your neck when your head's on the pillow or whatever. And I thought about it. I think, well, and we bought sort of one of these V pillow things so I could sort of sit up, but sleeping like that's not the greatest, to be honest. And I thought, well, how did I manage to sleep in the hospital? It's like, well, hang on, the back of the bed's propped up. So we went and bought sort of one of these foam wedges, so a bit like a wedge of cheese. So put that on there, and that was ideal because I could be laying down, but my head was on there, and it wasn't putting any pressure around my neck. So that was fantastic. But you know, that's something that you're not told. You just sort of you have to work these things out, don't you? So yeah,
that's great. Okay, I think we might have some questions. Julia's there, and we've got some questions, so we'll see whether we can answer them.
Thank you very much to both of you. It was really interesting, Paul, to hear your story, and some of the practical tips that you suggested were really helpful to people. I certainly learnt a lot. There are quite a few questions, and I will try to cover them. So first of all, a question about the size of a thyroid. So is surgery the best route for a larger thyroid? So a larger nodule. So you say you've got a nodule that's 3.5 centimeters by 3.5 centimeters. Is surgery going to be the best option for that kind of size nodule?
So I think what we need to say is that nobody really wants to have their thyroid out, even if it's half their thyroid. Remember, really what we want is our own thyroxine. We want our own thyroid hormones. So you don't really want to have your thyroid out unless you absolutely need it. Size of nodule or size of thyroid isn't an absolute. So I wouldn't say that you definitely have to have this out or definitely have to have that out. It depends a lot on your neck and also on where it was. Paul was describing how it went down, what we call retrosternally. And that's more likely then, because there's a little bit of a, that's more likely then to put pressure on the gullet and pressure on the windpipe if it's going down into the chest itself. So I wouldn't say there's a definite thing. If there are some new things that are coming out, but they haven't really hit the UK. And so some people are beginning to use what we call radiofrequency ablation. In Italy, they've used laser. Well, I don't think that will come into the UK, but radiofrequency ablation or some kind of ultrasonic machine to try and decrease the nodule may be what's used in the future. Quite difficult on Paul's one because they were multiple nodules, and that's a bit of a different thing. But you have to make sure that if you're going to do something like that, that it is for the that you haven't got an abnormal thyroid nodule, and also it's not available in the UK right now for benign nodules in most centres. But that may come in the next 5 to 10 years. But you don't have to have it. You know, if it's not causing you any problems, then why interfere? Why take away a piece of thyroid that might be working for you?
We're beginning to hear more and more about alternatives to surgery for treatment of nodules. In fact, one was about Dr. Tim Yusuf's, a radiologist in London, doing microwave ablation.
Yes.
Again,
so you can use microwave, radiofrequency ablation.
Yeah.
There's
it's always worth
ultrasonic
discussing
ablation.
with
There's
your surgeon as to whether there are alternatives for you, and there might be, but it might be because of the nature and the size of your surgeon of your nodule that actually you don't have many choices. But it's always good to discuss these with your surgeon, isn't it, just to make sure that you know all the facts and what options you have.
Yeah, the NHS doesn't have an enormous number of people doing this at the moment. It's not funded. Privately, it is funded.
Yeah, and it's very dependent on where you are in the country, isn't it?
It is a bit at the moment, yes.
With Graves' disease is another question. Is there a chance that you could only have a partial thyroidectomy, or with Graves' disease, is it inevitable that you will have a total thyroidectomy?
So in the old days, we used to do partials, but the problem is you get recurrent Graves, and it's working out exactly how much to leave. And then you've been trying to avoid radioiodine, usually, if you're having a thyroidectomy for Graves' disease. So it tends to be a near total or total thyroidectomy. There is, so Paul was talking about that if they felt that there had been a problem on one side, i.e. the nerve wasn't working very well, then sometimes when you're having an operation that's meant to be a total thyroidectomy, it will go to a hemithyroidectomy and then let the nerve recover and then go back another day to take the other side. So we don't, the only time, well, with Graves' disease, that is a systemic disease. So that means happens to whole body, and that means it happens to the whole thyroid. All right, I know I showed that picture of the one in the middle where for the technetium scan, the whole of the thyroid is abnormal. But there are people who have overactive thyroid that just have one nodule that's overactive, and then you can take part. But for Graves' disease, it's really, if you're trying to avoid radioiodine and also help your eye signs, then a near total or total, as much as we can do, is the best way to go.
Yeah, okay.
That's what we think at the moment, because going back on one side is not an option, really.
You don't want to
well, it is, but it's very high risk.
Yeah. There's a few questions about sizes of goiters. One about is the size of the goiter linked to how complex the surgery is, and how often do you end up having to open up somebody's chest when there's a retrosternal goiter? How rare is that? There's a lady here who said that she had a very large one and is the biggest the surgeon had seen. So is that a very unusual case?
No, so I do specialize in these really big ones. But it depends a bit. So sometimes they're really big and they come out the neck, and even though there's a little bit down, and then sometimes they will go down. It depends. It's very difficult sometimes to absolutely judge. So I will take one that I think might need a stenotomy, or what we call a mini stenotomy. That's half. You just go halfway down the chest rather than the full one that you'd see for some of the heart operations. I'll take that to our Liverpool Heart and Chest Hospital. But often, even of those that I take where I think there's high risk I might need a stenotomy, probably 50% of them I can still get up through the neck. It depends on the shape. So if it goes down like that, it's easier to get out through the neck. If it goes down like this, where you've got a big bit underneath, so it's like an iceberg, then they're more difficult and you might need a stenotomy. It will also depend on the nerve. You see, if the nerve's being pushed and pulled, then we might do a stenotomy to try and prevent it from getting really pushed and pulled. So there's multiple things that might need a stenotomy, but it is actually quite rare in the UK to have a stenotomy for, occasionally thyroids are right down in the chest. That's a bit unusual. It's not common. It's not common, I'd say.
Case by case basis. And if that was you just discuss it thoroughly with your own surgeon. And
they'll show you the CT. Yeah.
Yeah. There's a question here about mast cells, which I'm not familiar with. Somebody's saying, is there a connection between mast cells and thyroid issues, or is there any thinking about the sources of goiters and hypothyroidism and why it occurs in the first place?
Now, I personally don't know anything about mast cells and thyroid, so I'm afraid I don't think I can probably answer that specific question. But autoimmune conditions, I'm not an endocrinologist, but autoimmune conditions, there's some theories that they may start off with something like a viral illness that somehow drives the body to make these proteins, these antibodies against the thyroid. But we don't really absolutely know what triggers it. And often some people are also more predisposed to getting an autoimmune condition than others. So I'm not sure. I can't answer that question. I'd have to go away and look that up. I'm sorry, I can't answer that question.
Say that actually that's what the BTF medical query answering service. If the person who asked that question would like to get in touch after the event, then I'm sure we can find somebody who can help, who's a specialist in that area.
We can look it up as well.
Yeah. And there's people asking about follow-up from surgery as well. People worried about all the stories they hear about the NHS and the NHS services being so stretched, worried about the follow-up care they're going to get after their surgery. Should they be given a named contact, not if they're discharged home and they have issues in the following days and weeks? Should they be given a contact of who they can get in touch with back in the hospital if they've got any worries?
I mean, ideally, yes. I mean, it depends on the unit. We have a lovely endocrine surgical nurse who we give contact numbers. We give the ward contact numbers, and the surgeons are available through the ward if needed. So ideally, yes, but not all units are fortunate enough to have associated nursing staff to support us on that. But some kind of instructions to do, if it did, really swell up quickly, or you think you've got an infection or anything, definitely either go to your GP or go to the A&E department. That's what you should do, especially if it suddenly blows up on the day of the, day or the day after the operation. I would go to your A&E department because then there'll be people there to help you. That would be ideal, yes. But I'm not. We don't do that follow up. So I don't know what Paul's follow up, but it was 6 weeks. So a lot of people will have their thyroid function tested 6 weeks on their thyroxine, and then we might either put it up or put it down. We calculate it according to your weight, but it isn't always quite how it's all metabolized. So then we look at the thyroid function tests and we can increase them or decrease them and try and help you get the best dose for you as an individual with the levothyroxine. So that, I would say, most people would follow up at 6 weeks. I personally, because I have a suture that's removed, I see people at 2 weeks because I remove the suture myself, look at the scar and just make sure it's okay, but we'll always do the 6 weeks. So if you have a suture that dissolves, then it will probably be 6 weeks. And then it depends on where your follow-up is. Some people will have endocrinology follow-up, and others will have surgical follow-up, and it depends a little bit on what happens in your local area. I think, Paul, you said it's once a year you have some thyroid function tests. Is that correct?
That's what the surgeon's asked. He's asked for 4 months after I was fully discharged, and then annually after that. That's what he's asked the GP to do. Yeah.
So we're just trying to make sure that you're on the right dose. and that it's all relatively, that it's stable and that you feel okay with it, because not everybody feels absolutely fantastic on thyroxine. It's not a perfect solution, because I've got my own thyroid, even though I might need surgery in the future. I will make my own thyroxine when I need a bit of extra. Whereas if you're on thyroxine, you don't make any extra when you need extra. Yeah. And some days you might have a bit too much, and some days you won't have enough, because you just get the same dose every day. And so that can be, so some days you might feel tired, and some days you might feel like you've got loads of energy. And that's a bit of that's why I'm sort of saying you don't want your thyroid out unless it's needed. But if you're getting breathing, swallowing problems, then you are going to need to consider having part of it or all of it out. And for most people, I would say 85% of people, thyroxine is a really good way of just dealing with it. Well, everyone can use thyroxine. It's perfect.
And if people, we do hear from people who have ongoing problems with thyroxine, and I suppose the advice always would be, well, go back to your doctor and discuss, because often there are tweaks that can be made to the dose, aren't there? And
there are. Yeah, we're not meant to put any kind of dosage that suppresses the TSH, which is the hormone that comes from the pituitary that drives the thyroid. But you can tweak it around so that it's still within the normal range. So you can add a bit, and you don't have to just go up in 25 microgram doses. You can do alternate days. You can do a certain number for 5 days a week and 2 days a week. You can tweak it a bit. I agree. Julie, is that all right? Is that
Speak to your doctor. No, that's good advice. And people were asking about waiting times as well. We certainly hear from people who've got very, very long waiting times to get to see to get on the pathway for treatment for goiter, perhaps waiting up to a year for surgery. What options have they got if they, and I know that waiting times vary in different parts of the country, if your own wait is going to be, say, 42 weeks, can you ask to be referred to another part of the country where there's a much shorter waiting time? What are your rights?
So you're always allowed a second opinion, and that will depend a little bit on whether, so you're asking for a second opinion. The problem is that it's usually done by the GP. It can be done by the surgeon, but usually if somebody asks me for a second opinion, it's because I think that they would benefit from hearing something from somebody else because they're not sure or whatever. So they can look around. The problem is that what I didn't have a long waiting list, and then suddenly I had a whole load of operations that came my way, and then now I've got a long waiting list. So I do think that there is a bit of work to be done on waiting lists around the country, and that's a bit of work that I want to do as the president of the British Association of Endocrine Surgeons, is to try and a lot of it is access to theatres. There aren't enough theatre operating lists. Most surgeons are very happy to clear their waiting list. They'd be delighted because they like operating. But the problem is that there aren't the operating theatres and the staff available to actually clear these waiting lists. And there is a bit of a backlog still from COVID, I would say, in many areas, because benign thyroid cases did get put on the back burner. As well as parathyroid cases all got put on the back burner, and that has been a problem. So you can, but you'll probably just overload another area, and also it's not always quite what it seems in the other hospital.
That's a good point as well, isn't it? Yeah. There's a question here about papillary thyroid cancer. Somebody saying they had their thyroid removed in January 2020. Because they had a diagnosis of papillary thyroid cancer, and just wondering about what follow-up they should expect. Presumably they've been discharged, but what kind of follow-up there's going to be for with regarding to an ultrasound on their thyroid in the future?
Okay, so that will be very personalised. We normally stratify people to low risk, medium risk, and high risk, and it will depend on your operation, the type of cancer, and whether you've had radioiodine. So you will be stratified, and then there will be a variation on your follow-up. So some people will get discharged. Some people, if they've still got some thyroid, might have an ultrasound follow-up. Some people won't have anything. So it's very much stratified according to the risk that is initiated. There is a trial going on at the moment where we're only taking half a thyroid out for papillary thyroid cancer, the HOT trial at the moment. to see, but you may not get any ultrasound. If your thyroglobulin, which is a blood test that we do, is very low and you're in a low risk category, you might not get any ultrasound follow-up at all.
So it would be a good idea for this person to speak to their own team just to get the reassurance about what their care is going forward, really, because it's just a personalised.
It's a personalised thing and very difficult for me to say what anyone would do specifically. Yeah.
Thank you very much to both of you. I'm going to put my slide back, my BTF slide back. We've come to the end of our hour, and let's see if I can get that back. Can you see that, Cheryl? Hopefully you can see that now. It's been enormously helpful to have input from both of you. Paul, I'm sorry I didn't ask you any questions, but the questions were coming in for Alison, and I'm sure you felt you'd talked a lot anyway. Your tips and suggestions about and practical advice about what you'd been through, it's really, really helpful for other people watching tonight, but also in the future, because lots and lots of people watch this webinar, the recording of it, and us from BTF who've watched it as well. We've learned a lot, so we can impart that knowledge onto others, and just help people understand what they can expect when they're going into hospital. And most of us hopefully haven't been to hospitals before, so it's a daunting experience. So just to have your suggestions and advice is really, really helpful. There are a lot of resources on our website about thyroid surgery, preparing for it, recovering from it, on the BTF website. So if you want to find out more, please go to our website. We've also recently updated, with the help of Alison, our thyroid surgery leaflet guide. So if you'd like to go to that, you can find it on our website. Next week is one of the highlights in the calendar of the thyroid year, and it's International Thyroid Awareness Week. And we will be sharing information about thyroid surgery facts all week. So if you follow social media, if you could follow us, you can share the facts that we're going to be sharing. It's really, the purpose is it to raise awareness about the thyroid generally, but in particular next week about thyroid surgery, to help inform people so they're better prepared for what to expect. And finally, if you've enjoyed the session tonight, please consider supporting the work we do so we can put on more events like this in the future. You can go to our website and join the BTF, where we'll keep you up to date, or make a donation if you're able to do that. Any support is welcome. And a final thank you then to Alison and Paul for giving us their time today. I know you're busy people, and we really appreciate you deciding to spend your evening with us, and the information and expertise that you've shared with us. If anybody would like to watch the webinar in the future, again, that will be on our website or on our YouTube channel, and we'll be doing future events like this. So please keep in touch with us, and you'll find out what's going on next. So I wish you a good night. Thank you very much for joining us. Until the next time. Thank you. Bye-bye.